So once again, I thank you, all of you, to be here and for this opportunity to present some work, Brigitte and I, and some other colleagues, some from them are here in the room, from the French part of the Oslo Chronic Network, which is still tiny, but which is growing. We do not have conflict of interest, at least not financial conflict of interest. And to begin with, I would like to step back and look at what we already knew about persistent symptoms between long COVID. Some other speakers already done that. What we knew is actually quite simple. The persistence of physical symptoms, despite the, let's say, biological recovery or of an acute disease, or the biological remission. Of course, recovery does not make any sense if you still have symptoms, but from biological point of view, you understand the idea. This persistence is common in medicine. We have seen many examples. Irritable syndrome, bowel syndrome may appear after acute gastroenteritis. We obviously know chronic fatigue syndrome after acute viral infection. We know that some cases of fibromyalgia may follow inflammatory rheumatisms. Dysfunctional breathing is common, even in remission of asthma. And there are even very striking examples outside inflammation, such as patients with implantable defibrillator. We experience so-called phantom shocks. That is, they feel shocks, real shocks, even though no electric shock was actually delivered. And so, taken together, these observations strongly suggest that there are transdiagnostic mechanisms. They may exist alongside pathology-specific mechanisms, but we have to have this hypothesis to understand why there is no acute disease that will never follow, will never lead to persistent symptoms. And the point is that some of these transdiagnostic mechanisms could be modifiable, and then they could be targeted for intervention. And among these transdiagnostic mechanisms, who work focused on cognitive and behavioral mechanisms of persistent symptoms. Among these mechanisms, the well-known one is conditioning. It has well been, we have already heard about this in the previous talk. In very simple terms, it means that the brain is constantly learning from experience. For example, if someone breathes a certain smell in air enriched in CO2, this person will feel short of breath. And this is normal physical reaction. But now imagine that this happens several times in the presence of the same smell. And then after a while, the brain will learn to connect that smell with the sensation of breathlessness. And then later on, the smell alone, without any CO2, may be enough to bring back the same feeling. True symptoms, but not linked any longer to physical trigger. The physical trigger came once. So this is very important. Why? Because it shows that something quite simple may appear as well as in long COVID. The symptom can start with a physical trigger, but later be maintained by learned brain mechanisms. And of course, it does not mean that the symptoms is all in their head, all in our head, but maybe it's sometimes in the brain. And when studies looks after mechanisms explaining this breathlessness, this is not within lung or cardiorespiratory systems that the answer is to be found. It is in the brain functioning. So I just said that the brain never stops learning, but there is one important exception. Learning may stop if avoidance behaviors appear. Let's go back to the same example. If I am exposed again and again to that certain smell, but in this time in normal air without CO2, I will, or my brain will, unlearn what it has learned. And then my breath will go back to normal. In other words, I can unlearn what is happened before, but my breathing is now okay. But this process may not happen if I start avoiding the smell. And of course, it is perfectly understandable. If something keeps triggering unpleasant sensations, and that's why these defense mechanisms exist, The natural reaction is to stay away from it. But the problem is that when we avoid, the brain does not get the chance to update its prediction. A third mechanism is attention. And yeah, I want to be very clear. Saying that attention matters does not mean that the sensation is imaginary. It simply means that attention can change how strongly we feel a sensation. For example, this is an example I like much. If a wasp stings you in this room, probably you do not need to pay much attention to feel it. The signal coming from the body is so strong that you will notice it immediately. But now, if I ask you to notice the weight of your body on your seat, you will suddenly start to feel it more clearly. And this is not imaginary. I do not feel the body of my weight on the seat because I stand, but you feel it. But 1 minute ago, you were not feeling it. But it was real, it was already there. So what happened? That sensation is not imaginary. By directing attention to it, I have made it more noticeable. And now it's too late. If you try not to feel it, it's too late. But it's an important point. It's an experience you can share with the patient. And once again, it's partly in our brain. And we know for decades that driving attention is driving the way the brain is using some area to sense the body. And then last mechanisms, but there are many others, is interpretation. What matters is not only what we feel, but also the meaning we give to what we feel. That's probably why explanatory models are not just communication tools. They are intervention, I do agree with that. So if I experience some symptoms and think this is unpleasant but not dangerous, I will react one way. But if I think this is unpleasant and plus it meant that my body is in danger, or maybe I just make the problem worse, then the symptoms may become much more intense. And again, this is not in our head, this is in our brain, and we have decades of neuroscience about that as well. So let's go back to long COVID, what we expected in March 2020. We expected from the experience and from the knowledge we had at that time that some patients with COVID-19 will experience persistent symptoms, even without organic sequelae. Why not? It happens with every disease. So obviously, it would happen with COVID-19. We expected that virus-related inflammation will play a role in triggering the symptoms, but perhaps not in maintaining it, or a limited role. But we expected as well that psychosocial factors will play an important role in persistence of these symptoms. And finally, should it be true, they might constitute as well therapeutic targets. So obviously, reality learned us very soon that yes, some patients with COVID-19 did experience persistent symptoms, even without objectivable organic sequelae.
Thank you. So to assess the second point, with my team, we conducted a systematic review of studies evaluating the immunological biomarkers in patients with long COVID. So we had several inclusion criteria for this systematic review. First, we only looked at original peer-reviewed studies that assessed immunological markers. We wanted to have participants with long COVID defined according to the WHO criteria, and we also wanted them to have a control group consisting of recovered patients after an acute infection by SARS-CoV-2. Here is the flowchart of our research. So we started with almost 2,000 papers, and at the end, 30 had the inclusion criteria for the review. And I cannot show you everything, but this is the main figure of our systematic review. This is a representation of the biomarkers that have been tested at least 3 times in the papers. You have several cytokines and antibodies against SARS-CoV-2 spike protein. And on the vertical axis, you have the p-value. So the upper the p-value is, the lower the significance of the correlation is. I have added a red dotted line that is the threshold for significance in a statistical point of view, 5%. So all the circle below these lines are statistically significant correlation between one marker, each column is a marker, and post-infectious symptoms. And you can see that when you have one, I don't know if it's working, but for example, you have for IL-1B, you have one study that found a significant correlation just near to the thresholds, but we have also 7 other studies that didn't find any correlation. And that is the same for almost all markers. The only one that has 2 significant correlations is IL-6. And interestingly, for example, for the antibodies against the spike protein, you have conflictory results. We have 2 studies that found significant correlations, but they are in the opposite way. One is a negative correlation, and the other one is a positive correlation. So it means, well, then we assessed systematically the methodology of those studies, and unfortunately, we were very disappointed with the methodological quality. There were many methodological flaws. We discussed some of them before, but the first of all was a very huge recruitment bias. And then we were very surprised because many studies did not describe at all the patients and the controls. We didn't know anything about the comorbidities, and as Giuseppe said, comorbidities are very important to interpret the biological results. And also, we had a very big problem with statistical methods because a lot of tests are performed, a lot of markers are tested, and almost no study did perform a statistical correction for multiple testing. And also, almost no study did adjust for potential confounders, etc., etc. So I could not show you all studies, but you see there are very much flaws on those studies. So I've chosen just one study which has a good, I go back later, a good quality. It has been done by our colleague Olivier Robineau. It's a cohort study in the general population. And the population is from the SAPRIS cohort. Cédric will show you other results on this cohort. It's a French general population cohort. All the participants have approved SARS-CoV-2 infection more than 3 months ago, and they tested 14 biomarkers at the inclusion and 6 months later. And they did good statistics. They adjusted for age, sex, and BMI, and they did a multiple comparison correction. So at inclusion, they had almost 500 recovered patients from after an acute infection and 300 patients with long COVID. And 6 months later, there were almost 500 recovered patients remaining in the study. And among the patients with long COVID, 55 have recovered, and 200 had persistent long COVID. The characteristics of the patients are the same that Velena described before, so I'll go very fast. And they did indeed find many correlations between long COVID and some biomarkers. But those correlations did differ hugely according to the type of symptom and according to the duration of symptoms. For example, here you have the patients who had symptoms for less than 1 year, and you see that here they found all those correlations between certain biomarkers and certain symptoms, but the correlations are not the same depending on the symptoms. And when they apply the multiple testing correction, none of those correlations was still statistically significant, except for anosmia and 2 biomarkers. It means that all those correlations probably appeared by chance or because of bias. And then for the patients with symptoms lasting more than 1 year, you had different correlations with different biomarkers according to different types of symptoms. And this time, none of those correlations did stay significant after applying the multiple testing correction. So, and then besides, when they look at the patients who recovered after long COVID at 6 months, there were absolutely no difference between the biomarkers value and the fact have been recovered or not. So to conclude, I just wanted to say that our conclusions is that immunological findings in long COVID are very heterogeneous, as Giuseppe said, and there is no single consistent signature that has emerged, and I don't think it will ever emerge. The published significance finding, and there have been many of them, which has led to many confusion. Actually, they have not been replicated by other teams, with a few exceptions of IL-6. And we found major methodological limitations across those studies. So we think that if we want to continue on that way, we really need standardized guidelines on how to do those exploratory immunological studies in long COVID.
So, yes, it's not finished, Paul. So we might say that virus-related information could play a role, but probability is limited at best. So what about psychosocial factors? Before COVID-19, as I said, we already knew from other post-infection conditions that anxiety and depression could play a role in what happens after the infection, interacting with the infection. A good example is acute gastroenteritis. In that setting, studies had already shown that people with more anxiety or depressive symptoms during the acute illness were more likely later on to develop irritable bowel syndrome. So we had exactly the same hypothesis in March 2020, and we were lucky to be quick with our research team in European Georges Pompidou Hospital to set up this study and to follow the very first patient hospitalized for COVID-19, including the very first patient diagnosed with COVID-19 in France, and to follow them at 1 month and then at 3 months. And at 1 month, we measured depression and anxiety, and we showed that depression and anxiety were moderators, significant moderators of the risk of having persistent symptoms, physical persistent symptoms at 3 months. But there were patients with severe COVID-19 at the very beginning of the pandemic, so it's a very specific population. Another observation came very early from clinical practice and to other French colleagues as well. It was that the risk of developing long COVID was higher in patients, seemed higher in patients infected during the first wave than in those infected during the second wave. And using data collected through social media, we asked patients with long COVID to report the date of their initial infection. We then compared these dates with the distribution of infection in the general population. And you see what we found. The risk of long COVID seemed to be higher after having been infected during the first one than the second wave of the pandemic. We have in blue the general population, and in red the population recruited with through social media. And you may notice something even more striking on this graph, right? There is a sharp peak around the days of the national lockdown announcement. We might think it's funny, but it's also very thought-provoking, I think. Those people who were infected during these days of extreme anxiety for all the French population and the European population were those with the highest risk to later on develop persistent symptoms. So it cannot be explained by various variants, not between the first and the second wave, nor by vaccination. It was not available at the time. So it clearly suggests the role of psychosocial context. So as mentioned by my colleague Brigitte, replication is key in science. So we try to replicate this finding in our own patient cohort, and we did. We got exactly the same. Obviously, the control population is the same. It's the French population, but it's quite representative population. And we found that in our population cohort from Hôtel-Dieu, there were also massive overrepresentation of patients infected during the first wave, even if they had more opportunity to recover with more time from infection. And finally, it was more cleanly replicated in a French nationally representative cohort with exactly the same risk ratio in this work from the EPICOV cohort. Meanwhile, while gaining clinical experience, thanks to patients with long COVID we have seen, we developed a research program in epidemiology, and to do that, we were lucky enough to be able to use the data from the French Constance cohort. And the French Constance cohort is one or maybe the largest population-based cohort in France. It includes a little bit more than 200,000 people from the general population. They are followed over years. They were recruited from 2012 to 2019. And we had some data regarding psychological distress, for example, repeatedly years before the pandemic, and also some data thanks to the linkage with the National Insurance System database. And the SAPRIS study that was mentioned by Brigitte was nested within the CONSTANCE cohort. So we had data regarding persistent symptoms repeatedly, but as well as other measures, such as, for example, anxiety and depression at the very beginning of the pandemic, and persistent symptoms and psychological burden associated with persistent symptoms with the same tool that was mentioned by Evelina. So we had also serological test results. We were able to ask many questions. I will only focus on two. Was there a relationship between the experience of depression or anxiety before the infection and the risk of having persistent symptoms afterwards? The answer was yes, and it turns out that depression at the very beginning of the COVID-19 pandemic was the strongest, in our model, the strongest predictor of incident persistent symptoms 6 to 10 months later on. And also, maybe an important result, you know that women are more at risk to develop long COVID than men, and to my knowledge, it's not really explained to date. And depressive symptoms at the beginning of the COVID-19 pandemic explain 40% of this association between female sex and persistent symptoms. Importantly, the role of depressive symptoms was the same in men as in women, the same. But because women were more likely to have depressive symptoms, the weight was heavier among women. So yes, we thought that we have, together with other teams in the world, of course, some data suggesting that psychosocial factors are to be taken seriously and might constitute therapeutic targets. So you might wonder, how will you affect depressive symptoms at the beginning of the pandemic? Because we are now more 6 years later. But we also showed that the psychological burden association with persistent symptoms was associated with the persistence of the persistent symptoms. And that is potentially a target for intervention.